Okay, thank you so much. Njamba, right? Yeah.
Yes, please.
Okay, thank you. Thank you so much. So I don't think there is much more to say. Uh, the introduction has been made. My name is Kambole Danny. Yeah, as she said, I'm a graduating student from CVS School of Medicine. So I'm a, yeah, that I'm a medical doctor candidate. So I think I can go into the presentation. Is that okay?
Yes, please. Yes, please.
Okay, thank you. So I'm just trying to share my screen. I hope you guys are able to see my screen. Can someone confirm?
Yes, you can see it.
Yes,
Okay, thank you so much. Yeah, you should also cannot take my idea. So that's my name. Unfortunately, I couldn't do a very fancy PowerPoint because of yeah some reasons beyond my control. But either way, we just did we did up something to just make sure the conversation is flowing. So the person that was inviting me to this presentation told me it's more like a discussion and not really a presentation. So we'll try to balance both. I hope you're okay with that. So the topic of introduction today is shop. It's a pretty um, interesting and long discussion, but here we're trying to limit it to the aspects which are just basically important to this audience. Yeah. So could we have a volunteer, somebody to help us just kick us off and define what shop is? So if you happen to know your name, Pius, could you help us so that we know we are together? Hey, Pius, you don't want to help us? Hey, Benisha, could you help us define what shop is? According to you, what do you think shop is?
And I think so is
I think you're cutting, or is it just me?
uh, contain make clear.
Okay, Pius, I think you're cutting. Can somebody help us? Somebody else with better network? Hey, Benisha.
Hello, everyone. I'm not catching the question.
The definition of shop.
Oh, definition of shock. Maybe I can attempt the simplest version of it,
Yes.
which is ischemic loss or of blood supply to the cells and the muscles.
Okay, thank you.
Which
That.
mm,
Anybody else? Inonge.
Good evening, Doc. Another definition similar to what has been said: hypoperfusion of blood to organs.
Okay, that's a very good attempt. Let's take the last one. Inonge.
Oh, that was me.
Oh, this is Inonge. Sorry, I can't see. All right, thank you, Inonge. Anybody else? The last one.
Yes. I want also to add more.
Yes.
Shock is the hypoperfusion of the of oxygen or blood supply to the tissues due to cardiac failure.
Okay. Yeah. Thank you so much. So basically, the definition we almost have in mind when we think shock, we think of loss of blood supply, like a reduction in the blood supply, which will eventually lead to hypoxia, ischemia, and tissue death, and end organ failure. While that's correct, it is not entirely true because you know why most of us think that shock is we associate shock mostly with reduction in blood supply. I don't know if it's just me, but whenever we hear the term shock, we mostly think of hemorrhage, blood loss, and we straight away link it to just reduction in the blood volume, which will lead to tissue hypoxia, and tissue death. Yeah, that is a correct way of looking at shock, but it's not entirely complete. Because as we can see from this definition, I prefer to define it as a state of imbalance between tissue oxygen delivery and consumption. Because the widest, most of us, as you can tell from the definitions we were giving, we concentrated mainly on this aspect of shock, which has to do with tissue oxygen delivery, but we neglected another important of shock, which has to do with consumption. I can give a good number of examples, as we are going to see in the discussion, that will present as a shock state, but not entirely as a result of tissue oxygen delivery, but in terms of consumption also. So when we have a life-threatening condition manifesting with hypotension, which can be defined as systolic blood pressure of less than 90. Yeah, we know when BP drops below 90/60, we are looking at hypotension. So we can also define hypotension in terms of mean arterial pressure, which we are going to look at next. We'll look at it, how it's calculated, and its importance also. That's a way of also looking at it again. Then shock in general is a manifestation of circulatory failure. I don't need to re-emphasize that. Then, as we have already mentioned, what happens when you have circulatory failure to result in hypoxia, then which will lead to cellular death and eventually multi-organ dysfunction. Of course, we must be aware that some organs will generally fail earlier than others. And one of these organs that has a tendency to fail earlier when in shock states is the kidneys. So, but basically what we need to understand is that when we are circulatory failure, it will result in hypoxia, then cellular death, and eventually organ dysfunction. So before we go into discussion, I'd like us to look at these, just revise, I want to revise a bit of physiology in terms of blood pressure, the blood pressure physiology. So who can help us? What determines BP? What are the determinants of blood pressure? How is, okay, in other words, how do you calculate blood pressure?
Okay, let me try. So blood pressure is given as a product of the cardiac output and the peripheral.
Blood pressure, yes. Yeah. So blood pressure is.
Yes, go ahead. Okay, anyway, the person that said spoke first was correct. Blood pressure is considered a product of cardiac output times total peripheral resistance. And you can further break down the cardiac output to be heart rate times stroke volume. Then from there, you get the equation of blood pressure. It is important that I'm sure we are all aware of this equation and how BP is calculated and what determines it. But it's important before we start talking about this state of shock that we understand very clearly what determines blood pressure and how, when any of these parameters, the cardiac output, the total peripheral resistance, the stroke volume itself, and the heart rate are distorted, or maybe there's a problem with any of these, how this is going to reduce the reduction in PP and eventually lead to a state of shock. So it's important that we understand this. Then the other concept that is important to understand is, okay, before I get to how the body responds to hypertension, I think it's important to firstly outline what a MAP is. So, does anybody have an idea or know what MAP is? The mean arterial pressure, especially how it is calculated. How do you calculate the mean arterial pressure? So, the mean arterial pressure is going to basically help us in terms of how it is. When we look at how the mean arterial pressure, the figure there, it's going to help us give us an idea of how the perfusion is to the organs. So it is a very important figure. In clinical practice, the BP itself is going to tell you very little, but when you use it to calculate the mean arterial pressure, you're going to have an idea of how the tissue perfusion is in that particular patient. So how is MAP calculated? Anybody?
Okay,
Go ahead.
I can go on.
Yes, sir. Please.
All right. So the mean arterial pressure can be calculated as the when we add the diastolic pressure plus 1/3 of the pulse pressure, where the pulse pressure is equal to systolic pressure minus diastolic pressure. And when we make some derivative, when we derive, we can also calculate it as the when we multiply 2 by diastolic pressure plus the systolic pressure over everything divided by 3.
Oh, beautiful, beautiful. That's basically it. And what's the normal range for MAP? So anything between 70 and 100 millimeters of mercury is going to be acceptable as a normal MAP. So if you have something below 70, 65, most clinicians will quote that figure, 65 millimeters of mercury, then you could be looking at a MAP that is, as we said in the previous definition, that is a patient that is hypotensive. Yeah. So the other concept we want to look at before we get into the nitty-gritties of shock is how the body responds to hypotension. Does anybody want to help us with this one? Say somebody presents with BP of, say, 90/40 or 85/40, sometimes can even be 65/40. How is the body going to try to respond to such a low BP? Anybody? What are the mechanisms involved? It's very just the basic physiology you're thinking of, nothing complicated. So anybody to help us with that? Nobody? Okay. So when you are in a state of hypotension, which is low BP, there is going to be a detection of that state of hypotension in the carotid bodies and the aortic arc. I know we are aware that there are those sensors that are going to detect that. In the aortic arc, you have sensors that are going to send the impulse through the vagus nerve. In the carotid bodies, or the other way around. In the aortic arc, you are going to have sensors that will send the impulses through the vagus nerve, which is cranial nerve number 10. Then in the carotid bodies, cranial nerve number 9, which is the glossopharyngeal nerve. So those are going to send impulses to the nucleus of solitary tracts, commonly known as the nucleus tractus solitarius, in the medulla oblongata. Yeah. So when impulses get to the nucleus of solitary tracts, it is going to remit that information to other three centers, either the vasomotor center, the cardiac accelerator center, and the cardiac inhibitory center. So we are looking at the patient who is hypotensive. So when information gets there, it is going to be mainly of interest to the cardiac accelerator center and the vasomotor center. The cardiac inhibitory center is going to be inhibited. So what happens when information goes to those two centers, mainly the cardiac acceleratory center and the vasomotor center, it's going to send to some sympathetic ganglion, which is cervical sympathetic ganglion, which in further remits the information to the SA node and the AV node. And there's also some other sympathetic ganglion, which is going to remit information directly to the myocardial cell. We know that the sympathetic system is able to control everything. It's going to control the heart rate and the cardiac contractility. So the parasympathetic does not have a role on the inotropic effect of the heart. So the parasympathetic system is able to control the chronotropic effect and the chemotropic effect, but cannot control the inotropic effect. I hope we agree with that. So we're talking about the vasomotor center and the cardiac acceleratory center, which are going to send information to the SA node and the myocardial cells themselves. So it is going to make the SA node to work faster, which is going to increase the heart rate. Then also enhance the myocardial cells to contract a little bit faster, which is also going to increase contractility. Then it also has an effect on the conduction between the SA node and AV node, which is going to make the heart conduction faster. Then it has also a lusitropic effect, which is a shortening of the refractory period. You know that one of the reasons the heart rate is going to pump a little bit slower is because of that refractory period, which is going to be, if it's huge, it takes time for the myocardial cells to relax and start again. But when that refractory period is shortened, we're going to see that the heart rate is going to be improved. All this is working on those equations we talked about. Because if you improve your heart rate, it means you're going to improve your cardiac output. And when you improve your cardiac output, it means you've increased your BP and you are dealing with a state of hypertension. I don't know if you have got any questions on this part I've explained. Anybody?
Yes.
Yes, you have a question? Go ahead. There's no question?
No, just repeat on the
I can't hear you. I repeat on what?
last statement that you said. I was
Okay, so I don't know
the
exactly
last
what.
statements that you yes.
Okay, which one exactly? I was saying when you activate the vasomotor center, the cardiac acceleratory center, you're going to send impulses to the SA node to be stimulated and work faster, which is going to increase the heart rate. Then it is also going to stimulate the myocardial cells themselves to pump faster. So we're dealing with the chronotropic effect of the heart and the inotropic effect of the heart. Also the dromotropic, because the dromotropic effect, because the conduction is also going to be improved. Then there is also a concept of the lusitropic effect, which has to do with reduction in the refractory period. So all these things are going to eventually lead to an increase in BP, which is what we are targeting here. We're trying to increase the blood pressure and deal with the state of hypertension. Yeah. So I don't know if that answers your question.
Yes, thank you so much.
All right. So this is one concept. This is what happens. So we know that the sympathetic system usually uses the neurotransmitters norepinephrine and epinephrine themselves are going to be released, and the ones that
Excuse me, Danny.
yes, hello.
Doc, there is a question in the comment section.
Yes, go. Please read it for me.
Okay, just hold on. Victor Masenga is saying, kindly repeat what shortening of refractory periods is called in relation to chronotropic effect.
Shortening of the refractory period is lucitropy. So there is inotropy, clonotropy, dromotropy, and lucitropy. So that's what it's called. You can look up the terms even so that you get to understand them better after this presentation. But that's basically it. So I was saying the sympathetic system, is that fine?
Yes, thank you.
All right, sure. So we are saying the sympathetic system uses the neurotransmitters epinephrine and norepinephrine. Yeah. So what this does again is when those nucleuses are stimulated, they're also going to go to the adrenal glands and stimulate the adrenal medulla to produce more of these two neurotransmitters, eventually leading to the same effect. So another thing that is going to happen is that when somebody has got low BP, the perfusion to the kidneys is going to be reduced. And what that is going to do is that it's going to stimulate the GAG cells to release renin. And renin, we know I'm sure we know the renin and the angiotensin aldosterone system. Renin, which is released by the kidneys, is going to work on a protein released by the liver, angiotensinogen, and convert it to angiotensin. Then there is going to be angiotensin converting enzyme released from the lungs, which is going to convert angiotensin 1 to angiotensin 2. So what angiotensin 2 does, mainly two things. If you look at in other literature, they're going to tell you about four things, but for the purpose of this discussion, let's remember that angiotensin 2 does two things. One of them is it's a potent vasoconstrictor. Yeah. So if you ask the question, you say it's a vasoconstrictor, that's not enough. You mentioned that it's a potent because it's a very good vasoconstrictor. And then it also stimulates the adrenal glands to release aldosterone. Yeah. So what aldosterone does is it's going to work on the distal-convoluted tubules and increase the absorption of water and sodium, thereby increasing the blood volume. So when the blood volume is increased, the end-diastolic volume is also going to be increased. When end-diastolic volume is increased, we are going to increase the stroke volume. When the stroke volume is increased, we are increasing the cardiac output, and when the cardiac output is increased, we are increasing the BP. So those are the effects of aldosterone. Then we mentioned that angiotensin 2 is also a very potent vasoconstrictor. So what happens is when we increase vasoconstriction, we are increasing the total peripheral resistance, and we know that BP is equal to cardiac output times total peripheral resistance. And since we've increased the total peripheral resistance, we've also increased the BP. Yeah. I hope we are okay with that concept of the RAS. Any questions? No? Okay, we'll take it. There are no questions. So basically, I wanted us to understand this basic physiology before we go into shock, because if you understand this thing, you'll find that the topic of shock is pretty basic and straightforward. So we remember the body response to hypertension, and we understand the determinants of BP and the concept of MAP. So moderator, just to make sure we're all here, I can move on from here.
Yes, please. Can move on.
Okay. Then before I move on, are we familiar with I don't know how you pronounce this guy, but there's a law called Parkes' law, yeah, which talks about how the radius of any cylinder or hollow structure is determined by, yeah. So that's where the concept of total peripheral resistance comes in, because when you constrict the blood vessels, you know that you're going to increase pressure. That relationship with length is also very important. Anyway, so you can move on. So shock is basically classified in four ways. There is the distribution shock, there's the hypovolemic, there's the cardiogenic, and there's obstructive shock. So in this discussion, we'll quickly look at distributive shock and what it is. So basically, distributive shock is going to be characterized by peripheral vasodilation. And you'll see that in clinical practice, this is the most common type of shock we see. Distributive shock is probably most common, followed by say hypovolemic shock, then cardiogenic shock. Things like obstructive shock and are pretty not are very rare. Yeah, but I can assure you, if you walk into any hospital right now, you'll probably see one or two patients with distributive shock. So the basic principle of distributive shock is there is peripheral vasodilation, and we mentioned that PP is equal to cardiac output times total peripheral resistance. So when we say there is vasodilation, those vessels are dilated, and what that means is the total peripheral resistance is going to be reduced. And when we reduce the total peripheral resistance, we have in turn reduced BP. So these patients are going to present in a shocked state. Yeah. So they'll be hypovolemic, they'll be hypotensive, and eventually, if that is not remedied, they'll present with shock. So what are the common causes of distributive shock? One of them, again, one of the commonest is septic shock. So you find that sepsis, somebody has got an infection somewhere, there's a focus of infection, then that is not dealt with, then the body is going to try and put up an inflammatory response. So when that inflammatory response is sort of over-exaggerated, it's going to lead to septic shock, which is basically the physiology behind that is there is going to be those immunomediators are going to lead to vasodilation and eventually lead to a drop in BP. And if that drop in BP is sustained and below 90/50, as we saw, they are going to present with shock. Yeah. So the basic pathology is that those patients have got an infection. An infection is not controlled, then it leads to circulatory failure. So this is one of the commonest causes of distributive shocks. Then the other one is SARS, which is systemic inflammatory response syndrome. Yeah. So SARS, the physiology is basically just like septic shock, but in SARS, you know that you're going to see this inflammatory response is sort of even more over exaggerated. Then, unlike in septic shock, where almost, let me not say almost, all the causes are infective, in SARS you can have non-infective causes of this vasodilation. A common example are patients with burns. So patients with burns are going to, if the burn surface area is so large and the management is not so good, yeah, sometimes you can even properly manage them, but you find that patients with, when the burn surface area is just big enough, they'll eventually present with this state of systemic inflammatory response syndrome. Another group of patients are patients with pancreatitis. So in SARS, there are infective causes which can be bacterial and non-infective. The common causes are the ones I've mentioned, pancreatitis and burns. Then another cause of distributive shock is an anaphylactic shock, which is something that may be common with this cold weather. Yeah, so somebody reacts to an allergen, there is a immunoglobulin G released and all those things I'm sure you're very much aware of, and lead to a person presenting with distributive shock. Another cause of distributive shock is neurogenic shock. Um, in neurogenic shock, there is absence of the autonomic response. Somebody may be involved in an accident and they suffer maybe a spinal cord injury, and they lose their automotive response, and this is going to lead to vasodilation again and cause distributive shock. An endocrine shock is shock which will result from endocrine causes. A common example is the Addison's disease, is a common cause of endocrine shock. So of these, let's remember that distributive shock is probably one of the commonest, not the commonest causes of shock we see in clinical practice. And of these causes of distributive shock, the commonest of them is septic shock. Yeah, we're going to see a lot of patients with septic shock, not just in internal medicine, but also in surgery as well. Then hypovolemic shock. Hypovolemic shock is something I'm sure we are very, very conversant with, because it's sort of what comes to mind when somebody talks shock. So the basic physiology of hypovolemic shock is how I've said here, characterized by decreased intravascular volume and increased systemic venous resistance. Sorry about the spelling there. So, hypovolemic shock can be hemorrhagic and non-hemorrhagic. So hemorrhagic, as the way it says, somebody may be bleeding. Maybe they're involved in an accident. They have an open tibial fracture, they bleed, or a pelvic fracture, they bleed internally. They can have GI bleeding. Somebody may have, say, alcoholic liver disease, then they have varices and they bleed. Yeah. So all those causes, anything that will lead to hemorrhage and present eventually as hypovolemic shock will be classified under hemorrhagic. Then there are non-hemorrhagic causes of hypovolemic shock. Things like diarrhea could be one of them, or vomiting. If somebody vomits or has diarrhea for too long and there isn't replacement of those fluids, they would eventually present with hypovolemic shock. That is why it is very important that patients that are presenting with diarrhea diseases or even vomiting, we quickly replace the fluid they are losing. This is a very big concern, especially in pediatrics. Yeah, it's a very big concern. You would see this kid comes in looking probably healthy, and because of diarrhea, if you are a carefree doctor, you would probably even send them back home. Oh, this baby is fine. But you find that maybe you even given the mother ORS, the baby is not able to keep that ORS down, and they continue vomiting and have diarrhea. 4 days later, though, that the baby comes in as a PID. So remember, hypovolemic shock can be hemorrhagic and non-hemorrhagic. So as we are looking at this, we remember that concept of a BP, which is controlled by, which is the cardiac output, total peripheral resistance. So when somebody has got hemorrhagic shock, their blood volume is going to decrease, which is also going to decrease the diastolic volume, which is going to decrease the stroke volume, which will eventually decrease the cardiac output and eventually lead to a decrease in BP. Yeah. Cardiogenic shock, you can have any cardiogenic shock will be defined as anything that will prevent, will decrease the cardiac output. So remember, BP is equal to cardiac output times total peripheral resistance. If we have a decreased cardiac output, then we are decreasing BP direct. So anything, things like cardiomyopathies, I'm sure we know about the cardiomyopathy, the restrictive and all those dilated cardiomyopathies. Those conditions, those conditions reduce the cardiac output. Yeah, so they will reduce the cardiac output and lead to a reduced BP. Arrhythmias, both tachyarrhythmias and bradyarrhythmias, if the heart is not pumping the way it's supposed to, it's going to eventually lead to reduction in cardiac output. Then there are also mechanical causes, like the valves, the aortic valve, if there's aortic valve stenosis, or even the mitral valve itself is stenosed, then even though we may have adequate blood volume, the blood is not being pumped out, so that will reduce the cardiac output and eventually reduce the BP. Yeah, so that's about, we have cardiomyopathies, arrhythmias, and mechanical causes of cardiogenic shock, which are most commonly valvulopathy. Yeah, so problems with the mitral valve, problems with the aortic valve itself are going to reduce the cardiac output and eventually reduce the BP. We have the last form of shock I listed here, the obstructive shock. So obstructive shock is can be due to pulmonary vascular causes. So one of the commonest causes of this is a large pulmonary embolus. So when you have a large pulmonary embolus, so the basic principle of obstructive shock is that it results from reduced movement of blood. from the right ventricle, because the blood has to move from the right ventricle, goes to the lungs and comes to the left. So if there is any obstruction in that route of movement of blood from the right ventricle going to the lungs, if there is any obstruction there, you are going to have obstructive shock, and those are the ones called pulmonary vascular obstruction. So if you have got an embolus, none of those pulmonary vessels, then you could have obstructive shock. Then another cause is pulmonary hypertension, which also is listed under pulmonary vascular cause of obstructive shock. Then mechanical causes. Mechanical causes are those causes which are going to reduce the venous return, because from the peripheries, blood has to go through the venous system and come to the right ventricle. So if there is any obstruction, mechanical obstruction, which is going to prevent that from happening, you are going to have a type of shock called obstructive shock. So one of the commonest causes of this type of obstructive shock is I don't know if I'm sure we are familiar with the pneumothorax. So patients usually find that the patient is in an accident and they have pneumothorax. It's going to reduce the venous return to the right lung and eventually lead to obstructive shock. Another cause is cardiac tamponade. Yeah. So cardiac tamponade and pneumothorax. Yeah, these are the things that we are going to list under these causes of obstructive shock. We should be able to, I know topic for another day, I'm sure, but we should be able to be able to recognize a patient who has a pneumothorax, especially on physical examination. I think we'll talk about it when we look at evaluation, how we're going to evaluate those patients and sort of know that this patient could have a pneumothorax or even cardiac tamponade, and you know just the basic management, because these are emergencies which are common. You could be on a bus or wherever you're going, maybe traveling long distance, and you have in an accident and somebody has a pneumothorax. The management could be very simple if you know it, but if you don't know it, could be still very difficult. Yeah. So, pathophysiology of shock. So the basic principle is that before I go on, I think, are we together? Are there any questions on the previous chapter? Any questions? Okay, if there are no questions, can we just have someone confirm that we are here?
Yes, Doc, we are here, we are following.
Okay, thank you so much, Abdul.
We are here, Doc.
Okay, great. So that's about the classification of shock. We remember there are basically four classifications of shock. There is the obstructive shock, there is a cardiogenic shock, hypovolemic, and distributive shock. In the pathophysiology, we already talked about this. Basically, what happens in shock is that we're going to have a reduced blood pressure, which is going to lead to hypoxia and tissue ischemia, and eventually lead to multi-organ failure. So that's basically the pathophysiology of shock. And in looking at shock, it is clinically classified into the other classifications, which will have four, but I think I've adopted this one. It's easier for me to remember and it makes more sense to me. Yeah, but don't be surprised if you go in a book and find others have classified it clinically into four stages of shock. So you have the pre-shock or the compensated shock, and then you're going to have shock itself and end organ dysfunction. So here the important thing to understand is that we need to be, we'll see when we look at the clinical examination and the investigations, we need to be able to recognize the state of shock and say, okay, this patient is in shock. And then we should be able to differentiate whether this shock is compensated or not compensated. Yeah. So every patient that is in shock is going to have hypotension, yeah, which is blood pressure below 90/50. And whether this shock is compensated or decompensated is mainly going to be determined by the pulse. So normal pulse is range between 60 and 100. So in shock that is compensated, we are going to find that the pulse is going to be high because we remember that cardiac output is heart rate times stroke volume. So when we raise the heart rate, which is the pulse, we are going to raise the cardiac output. And when the cardiac output is raised, we know that the BP is also going to be raised because BP is equal to cardiac output times total peripheral resistance. So of all the things, I think personally I would like you to remember that shock is classified mainly into this pre-shock or compensated shock, then shock and end organ dysfunction. So the difference between pre-shock or compensated shock and shock itself is that while both patients are going to have hypotension, the main difference is that in compensated shock we're going to find the pulse is going to be high because it's trying to compensate for that. But eventually the body is going to fail to compensate. It can't keep on compensating forever. And this patient is going to have shock. And when the shock state is progressive, we allow it to progress, then we are going to have end organ dysfunction. Yeah. So the goal of managing shock is to prevent a patient from progressing from this pre-shock state to a shock state and eventually end organ dysfunction. So we're going to see how we can help do this. History and physical examination. Are we okay with the pathophysiology? I need somebody to help us here. Benisha, what do you think are the common physical findings or when a patient, Benisha, you're so here. When a patient comes to you, hello?
Yes, yes, doc.
Yeah, a patient comes to you in, they have been bleeding. When an accident, they are bleeding. So what are the things you're going to look out for on history and physical examination? Anybody?
Okay, I think first of all,
Just go ahead.
like, yeah, are you able to get me?
Yes, very clear.
Yeah, I was saying, I think I would first of all, since you said they have been bleeding and stuff, um, first of all, I think the patient has to be taken care of. That is, we have to to give fluids and stuff to maintain
No,
the blood flow.
before you go into management, I'm just asking for history and physical examination. Yeah, I know this is an emergency. Before you take history, it has to be ample and you do a TLS. But let's imagine, let's for a minute, let's forget about that. We'll talk about it in management, but just in history. Okay, maybe it might not even be that obvious that this patient was bleeding, but in a patient with shock, what are you going to ask? What are you going to ask for in history and physical examination? What are you going to see to help you make a diagnosis of shock?
Being on physical examination, I have to check about the peripheries, like from the hands, you'll be able to detect the cord peripheries, meaning like there's no proper perfusion of blood,
Good,
yeah, to those extremities.
good. And what else? Anybody else to help with Dr. Majata?
Okay, so just to add on, I think on the history we can also ask. I don't know if the patient is able to speak very if to ask what time the bleeding started, and also they can maybe give an estimate of how much blood they lost, and say no, it was a lot, or maybe the people that have come with they can say no, they lost a lot of blood. Yes, the amount, yes, just to make an estimate also. And then I think also on physical examination, what can also make sense is also checking the respiratory rate.
Yes?
Yes.
Why don't you check the respiratory rate?
Oh, okay. Okay, for the respiratory rate, I think maybe to just give us an idea if, depending on the rate at which they are breathing, it can direct us to if it is a hemorrhagic shock, and also to help us what to use in terms of fluid management.
Okay, all right. That's Doctor who? What's your name, sir?
My name, Armstrong Brooks.
Okay. Oh, Brooks, Dr. Brooks. Yeah, that's Dr. Brooks. Thank you so much. The last person to help us.
I'm on examination also. I think also if you check for pallor, and then also on the history, the patient can also come complaining of weakness.
Weakness, eh? Okay, good, good. So, okay, basically what you've said. So, I earlier mentioned most of the times the patient in shock is an emergency. Yeah, there's no time to start taking a history. But it's important as doctors to know what a patient in shock will present like. And of course, eventually after you resuscitate them, you will need to take a history and try to narrow down and find out the cause of shock. That's important. So you can have a class of shock called undifferentiated shock because sometimes you cannot just tell, and that's most of the time you won't be able to tell. Say, this is cardiogenic shock, unless the obvious causes of shock like hypovolemia. Sometimes you may not be able to tell. Say this is the type of shock. So you have that class of shock called undifferentiated. So when you're taking history, you're trying to look at what could have caused this shock and try to sort of differentiate from the other types of shock and uh, uh, make a more specific diagnosis. So most of the things we've talked about in history, you can look at the hands, you do the capillary refill, you can do look at the hands as they said, they can be pale, you could have cold hands, cold extremities which are clammy, then you can look at the pulse in compensated shock is going to be pretty high and thready. Then other things you can do yes, those types of shocks I told you, which results from, say, cardiac tamponade. So in cardiac tamponade, patients will present with specific signs. For example, the backstrap. Pius, what is the backstrap?
Um,
Yes, what? Yes, Pius. You haven't been to medicine yet, eh?
no.
Oh, okay. So we'll take that as an excuse. Okay. So there are things you look out for. A patient with cardiac tamponade is going to have an elevated jugular venous pressure, then they're also going to have muffled heart sounds. Muffled because when you auscultate them, the heart sounds are going to sound distant, like they're on a distance. Then they're also going to have hypotension. So those three things are what comprise the backstrap. Then if, for example, this cause of shock is say pneumothorax, you're going to have all those signs of pneumothorax. Reduced air entry on the side that is affected. There's going to be tracheal deviation to the normal lung. The patient is going to be tachypnic. Yeah, they're going to have difficulties in breathing. The respiratory distress is going to be apparent. Then you're going to see all those things. So the history and physical examination, the signs and symptoms are going to mainly depend on the type of shock. If somebody has, say, anaphylactic shock, then you could ask about any history of allergies in the family. Or this patient, is this patient prone to allergies? Are they asthmatic? Do they have a rash and all those things? Just to try and narrow down the cause of shock. So the list of history and physical examination, signs and symptoms is very broad, and
Doc,
you could spend the whole day just listing things that could cause shock. Yeah. Then,
there's a question.
pardon?
There is a question.
Yeah,
Somebody is asking for. Somebody's asking for the spelling of the triad, the name of the triad.
Bextrad. It's called Bextrad.
The
Look
what?
it up. Bextrad.
Like, I'm not getting the pronunciation right.
Bextrad.
All right.
So investigations. So investigations are pretty obvious. You're going to do a full blood count, and there's probably a differential. So full blood count, you could expect to see things like hemoglobin is low, then differential count is going to help you in states of, say, septic shock. You're going to see lymphopenia, lymphocytopenia, all those things, all those nice things. Then you can do liver function test, kidney function test, because we know that the end result of shock is organ failure. So you need to investigate the end organs. I told you the commonest ones: the liver, the kidneys, and the heart itself. So you do liver function test, kidney function test, you do cardiac enzymes. Then you can also do D-dimers, because sometimes shock could be as a result of myocardial infarctions. Oh, D-dimers, sorry, D-dimers. You do, maybe there is a pulmonary embolus, or yeah, for that. So D-dimers are going to help us with that. Cardiac enzymes are going to help us with in case you do the troponins and others to try and rule out myocardial infarction as a cause of cardiogenic shock. Then you also do ECG. ECG is going to help us with a lot of things. Then diagnose a lot of causes of cardiogenic shock. Then even if we have things like the cardiac tamponade that I'm talking about, you are going to see this. You are going to see the signs of such on ECG. Then you can do an echocardiography. Then you can do also a chest X-ray, which is one of the things we are going to do first, because that's what mostly is available. And we can see a lot of things that can help us diagnose the cause of shock on chest X-ray. Then basically you can just do a complete septic screen, and it is going to help us try and rule out different things that could cause shock. Then management, we mentioned that, okay, it's important to know that the management is going to, is mostly, the principles are the same, but it may differ depending on the type of shock you are thinking of. But some things are always going to be there. For example, if a patient presents with shock, you are going to follow the TLS protocol, because this is an emergency. You do your airway, breathing, you do your primary survey, which is airway, breathing, circulation, the ABCDs. I'm sure we are aware of those things. Then you do your secondary survey, and immediately you're going to administer fluids. So the fluids of choice are the crystalloids, the ringers, lactate, normal saline, and if you have blood, whole blood is also is also very preferred. Then broad spectrum antibiotics, if you're suspecting, say, septic shock, are very important, because you don't get your blood culture results just and then, but as we are waiting culture, we need to do we do the we give the patient some broad spectrum antibiotics. Then there are, for circulatory support, give antihistamines if you're suspecting this patient may have an allergy or what. You give them antihistamines and epinephrine, even steroids. These are going to help us with increase the total peripheral resistance and eventually raise the BP. So this management I've listed here, I know the reason why I didn't put a lot of detail here is because it's not very important to this audience, but we need to remember that the patient that presents in a shocked state is an emergency, so we follow the ATS protocol. We do the primary survey, the ABCs, and all those things. Then you do a secondary survey, and we need to know that these patients will need IV fluids or blood. Then they also need antibiotics. They also need antibiotics, and yeah, this is the basic management of a shocked patient. I think that's it. I don't know if you've got any questions at this point before we look at I've got two questions coming up. Don't know if you've got any questions for me before we ask you. Question? No?
Okay, so there is a question in the comment section.
Yes.
It's from Veronica. She said she joined a bit late. What did you say about the stages? I'm not sure which stages also.
Yes. Veronica. So, yeah, I was talking about under the pathophysiology of shock, where we classify clinically shock into a compensated shock which is not compensated, then end organ dysfunction. That's, I think, what you're asking about. So we said here that both in compensated shock and the state of shock, there is going to be a hypotension. But the main difference is that in compensated shock, we are going to see that the pulse is going to be elevated. And because the pulse is elevated, most of these signs we talked about for shock are not going to be apparent because this patient has a sort of compensating. So those things you mentioned, like cold clammy hands or even reduced capillary refill, we may not see them because this patient is compensating for that shock, trying to hide the shock state. But once shock progresses to a decompensated state, then we are going to start seeing these signs of shock are going to be apparent. And the pulse is going to be within normal or most likely even below normal. So it's going to be, could be between 60 and 100 or even lower than that. Then the last stage of shock, which we are all scared of, which we don't want to see, is end organ dysfunction. And we said the commonest organ, probably the organ which is going to fail first, is mostly the kidney. Then others may follow the liver, the heart, and the organ. So I don't know if Veronica, you can confirm if that's what you're asking about.
She's confirmed that's what she was asking about. Thank you.
Thank you so much. Any other question? Okay, so at this point, before we get to
I want to ask, there's one doctor was saying, why do...
yes, go ahead.
Yes, can you get me?
Yes, I can hear you.
Can you get me now?
Yes, I can hear you.
Okay, there's a question that, yes, there's this question that why IV fluids are not recommended in cardiogenic shock?
Oh, okay. So, what do you think? What do you think? Or anybody to help us with that train of thought? What do you think IV fluids are not going to be recommended in cardiogenic shock? Uh, sorry, yes,
Yeah, I wanted to give it a try.
yes.
Yeah, because the heart is the source more like of it's the pump that would pump blood to all parts of the body. And if the pump fails, no matter how much fluid you give, it will still fail to pump. So giving more fluid, it will more like, again, give it more stress. So I think that's why you don't give more fluids again.
Okay. So, before I even, are there any thoughts for this? So, I would like to recognize the presence of. Mhm. Are there any thoughts?
Okay. I was thinking in the lines of, for example, you mentioned that one of the things related to cardiogenic shock could be dilated cardiomyopathy or dysrhythmias. So, for example, let's say that the cause of the cardiogenic shock maybe it was dysrhythmias. So, if we give IV fluids, we know that some IV fluids they contain ions like potassium, sodium. I think those also may also maybe alter the cardiac action potentials of the heart. I think something related to that also, in addition to what Benisha said.
Okay, yeah, that's all those thoughts are true. But I don't think I agree with that trend of thought of not giving IV fluid in cardiogenic shock. The reason why I think it's not entirely true is that it will take you time to even just know that this is cardiogenic shock. When a patient is presenting an acute state, you are not going to know that this patient has got cardiogenic shock. That's the first thing. So by the time you are doing your investigations to to actually determine that they have cardiogenic shock and you decide to always stop giving them fluids, it may be too late. So what I've seen done and what I've learned over the past few years is that the patient presents in shock state, they need fluids to give them. Yeah. The risk benefit ratio you have to draw up as a doctor and you use the clinical argument to see that is me giving them fluids which is going to kill them earlier between you giving them fluids and not giving them fluids. Because even when they have, say, cardiogenic shock, the cardiac output is reduced. If you improve the blood volume, chances are that the cardiac output is going to also improve a little. Yeah. So that's my thought. I've not come I've not encountered any teachings in the last few years that say strictly no fluids in cardiogenic shock. No, I have not. I would be lying. Yeah. So it's something we need to. I would need to also look in, and I'll be able to send my feedback through a Benisha. But that's my thought. But to reason with the people that are saying let's not give fluids, it's most likely the first thought that was given. I think it's by Benisha that the thought is that when somebody has got a cardiogenic shock, the pump is not working properly, and when you give them fluid, they're going to have fluid overload, and that is going to kill them. Yeah, that's a correct trend of thought. But by the time you get to the diagnosis of cardiogenic shock, you might have lost a patient who did not actually have cardiogenic shock. So my advice is that let's give fluids until, yeah, that's my thought. But I'll do some research and also send my feedback. Are there any other questions? No other questions? Okay, if you don't have questions, you can, or you are shy like me, you can type them. We'll look at them. So I was about to say, recognize the presence of one of our senior colleagues, Dr. P. Jingio. She's attending the meeting. She's a JRMO practicing at Kasama Central Hospital. Yeah. So thank you so much, Doc, for joining us. So the case scenarios. Benisha emphasized that there should be cases. So I tried to look around and I've got two case scenarios. So the first one is a 3-year-old child is brought to a clinic with complaints of diarrhea and vomiting for 3 days. The child has features suggestive of severe dehydration and shock. Which of the following is the appropriate initial volume of fluid suspension administered to this client at the onset of shock? So before we answer this question, somebody can help us. What are the features again suggestive of severe dehydration and shock? Somebody remind us. So they are saying this patient presented with complaints of diarrhea and vomiting. So what are the features of dehydration and shock? Come on, guys, come on.
What's the question again?
The features which are suggestive of dehydration and shock. Or even just dehydration.
Diarrhea.
What are they?
Diarrhea and vomiting for 3 days.
No, okay, we know that history, but on examination, what are you going to do?
Oh,
I think we would see tachycardia, also rapid breathing.
Pardon? Low BP, tachycardia, yes, depending on the stage of shock. And what else?
I think rapid breathing and also sunken eyes.
Okay, yeah, all those are signs of, yeah. Then another very common thing, which is probably the most objective way of hypovolemic, telling whether a patient is hypovolemic is looking at the urine output. Hello?
Capillary
Somebody
refill
said,
time.
pardon?
Capillary refill time. Capillary refill
Yeah,
time.
yeah, that's all correct. We look at all those things. Appear refill time, the pulse, the hands are going to be cold and clammy, they could be pale. Yeah, so I was saying another thing we need to be looking at is urine output. You know, what is the normal urine output?
Can I try?
Yeah, go ahead.
0.5 to 1.
Okay, good. So 0.5 to 1 milligrams per kg normal urine output. So we need to be looking out for the urine output also. Okay. So what type of dog does this patient have? Anybody?
Hypovolemic.
It's hypovolemic shock. Okay, good. So now to the question, what type of fluid are we going to give the patient?
And since the patient has got diarrhea, so there's a high chance that they are losing iron. So I think the best fluid you can give them is Ringer Lactate, since it's the only one here that has got potassium ions. I think
What's your name, doctor?
Inonge.
Oh, sorry, I can't.
I can go for Ringer's lactate, which is G.
Why? Why are you going for Ringer's lactate? Okay, do we have anybody with a different answer? Okay, nobody. Anyway, the answer I also think is correct is D. To give 20 minutes per kg of Ringer's lactate. Then case 2, a 23-year-old man is brought to the emergency department after a motor vehicle collision. After a motor vehicle collision. On presentation, the patient has a blood pressure of 80/50 millimeters of mercury, a pulse of 120 per minute, and a respiratory rate of 30 per minute. He has cold extremities, mottled skin, weak jugular venous pulsations, and a Glasgow Coma scale of 12/15. The folic acid diet is in place with a minimal urine output. What is the primary goal of treatment for this patient at this time? So before we go to the question, what abnormalities are we seeing here? In terms of the vitals and the presentation, what are the key abnormalities? Quickly, let's finish the presentation. So abnormalities, anybody to help us?
Yeah, you can try.
Yeah, go ahead.
Yeah, the blood pressure is very low.
And so what do you consider the normal, why do you think it's low?
Maybe let's say the body fluid. Okay, maybe the patient has lost a lot of blood.
So what, okay, yeah.
So the
Uh,
the
what
patient
level,
has lost most of it. Yes?
yes, what level of blood pressure are we going to say is normal, or which one is not low? I agree the blood pressure is low, but
Okay, the normal is 120/80 there.
okay, that's not completely correct. Uh,
Yeah?
so we mentioned earlier that if systolic blood pressure is below 90, then we are going to say this patient is hypotensive. Yeah, so we can see systolic blood pressure is 80 and diastolic 50. We can definitely conclude that this patient is hypotensive. Yeah, so 90 over 60, anything above that, we are okay. But 80 over 50, that's definitely there. I think I need to mention here that there is this concept in the community, especially with clinic officers. If we have any here, I don't mean any disrespect. Clinic officers, nurses, you find that a patient goes to the clinic, they tell them, no, blood pressure, if it's not anything above 120 over 8, it's low. So as long as you find that the patient has got BP of, say, 100 over 75 or 100 over 80, because the clinician thinks that low, you'll find most of the patients will tell you, no, nalikuwa low BP. I'm sure we've heard a lot of patients say that, nalikuwa low BP. But I don't believe there's anything, such a thing as low BP. Yeah. So BP that is, it can be below 120 over 80. As long as it's not below 90 over 60, it could be normal blood pressure. Yeah. The 120 over 80 is one they did for an average population. I don't know which population they even measured. Yeah. So that's the case. So you're right, Doc. BP is low. What else? What other abnormalities? So you tell us the abnormalities normal range. Huh?
I think the pulse is too high, as well as the respiratory rate.
So why do you think the pulse is too high?
In this case, we are told the pulse is 120, and initially said the normal pulse is around 60 to 100.
Don't quote me. Quote the books, though. But you're right, yeah. So normal pulse is between 60 and 100. Yeah, and this is 120, so it's high. The respiratory rate?
The respiratory rate is high as well.
What's the normal respiratory rate?
16 to 22.
What?
16 to 22.
Dr. Manjata, do you agree?
Yeah, some books they say 18 to 20. I mean 118 to 120. So I'm not sure.
Respiratory rate. So anybody else? I personally, from the little experience I have, respiratory rate that is above 20 is going to be considered to be high. So normally we have a respiratory rate between 16 and 20. Yeah, most people fall within that range. Unlike the pulse, which is some people, like for example myself, if you are a sports person and all that, you find that your resting pulse could even be below 60, some over 50, 55, like that. Respiratory rate, most individuals, adults, will fall within that range of 16 and 20. The pulse, respiratory rate that is 22 is a bit is on the higher side. Yeah. Any other abnormalities you are seeing?
Yeah, we also thought that the proximity is a cord, and also the motor of the skin with the weak jugular venous pressure or position, sorry. And the Glasgow Coma scale as well is lower than the normal, which is 15 out of 15.
What's the lowest GCS you can have?
The lowest you can have, that is, you mean if you are normal, that's the abnormal now?
No, like if somebody has, since we've agreed that it's so the normal GCS is
The lowest,
15.
So the lowest is 3.
Okay, good. All right. What else? What else? Other abnormalities?
reduced urine output.
Yes, thank you. Yeah. So we've now established the many abnormalities. This is a proper shock patient. So what do we think could have caused this shock? What type of shock are we dealing with?
I'm thinking of neurogenic shock.
Why?
Because of the reduced Glasgow Coma scale, somewhat suggestive of neurological defect.
Okay. Any other thoughts?
Look, this looks like hemorrhagic shock. There might be internal bleeding, seeing that there was a motor vehicle collision. That's what I think. So, yeah.
Okay. Thank you. Any other thoughts?
Okay, I also think the same. It is hemorrhagic shock
Why?
because just the same way I think Samuel has said, them due to collision, maybe this patient has got some bleeding, so maybe the victim has lost some blood. Yeah,
Okay.
I think so.
Yeah, thank you. So, Dr. Majata, if the patient has lost a lot of blood, the perfusion to the brain is also impaired. So that could explain the low GCS.
Oh, all right. Thank you, Doc.
Not necessarily that when somebody low GCS, they have got other type of shock. So the question here is, what is the primary goal of treatment for this patient? And the options are is to restore normal intravascular volume. What do you think is the answer? What is the primary goal of managing that patient?
I think to restore normal intravascular volume, you can give blood or IV fluids like Ringer's lactate.
Oh, okay, yeah. What's the answer? Yeah, okay. Any other thoughts? What do you think is the primary goal of managing this patient? What are we trying to achieve?
Look, I think it's B, to restore adequate perfusion, tissue perfusion.
Why do you think so?
I think so because at this point we are more worried of organ failure, seeing that this patient already has a low urine output, so we might be suspecting that there might be acute kidney injury. So our goal, and also a deteriorating brain function from the Glasgow Coma scale. So at that point, we are more worried of organ damage.
Okay, thank you so much. What's your name, doctor?
And Lovu Samuel.
Okay, Dr. Samuel. Any other thoughts?
I think I also second B. Yeah, I second B as well.
Why?
To restore adequate tissue perfusion.
Why? Why is that?
Maybe I can try.
Yes, go ahead, doctor.
Yeah, it is to restore adequate tissue perfusion. Maybe let's say this victim has lost blood. You know that blood is needed to supply the maybe oxygen in the tissues. So that blood has lost. So I think the primary care is just to restore adequate tissue perfusion so as to prevent the tissue failure. So those organs might fail, like brain, kidney. Yeah.
Anybody with a different thought? Last one.
Yeah, Doc, I wanted to contribute something.
Yes.
Yes, we know that the basic unit of a living organism is a cell.
Yes.
And we even defined earlier that the end result is tissue perfusion. So, like in shock, there's hypoperfusion. So, our main objective is to restore tissue perfusion, which is the main primary of, or which is the primary function of actually the living organism.
Okay, thank you so much. So most of you, I think you're getting it right. The primary goal of management of any shock patient is to restore adequate tissue perfusion. If you look at all these, are incorrect. To restore normal intravascular volume, to restore a blood pressure of greater than 120/80, to normalize urine output. So all these are all leading to the answer B, which is to restore adequate tissue perfusion. When you have normal intravascular volume, you're going to restore adequate tissue perfusion. When you have a blood pressure greater than 120 over 80, you definitely restore tissue perfusion. When you have a urine output that is within the range of 0.5 to 1 mils per kg per hour, you're going to restore adequate tissue perfusion. So that's the key with this patient. Everything is correct, but the basic principle of management of shock is to restore adequate tissue perfusion. Everything else is a bonus. Yeah. So I think I end here. Thank you so very much. I don't know if we are going to. We have any other question?
Okay, I was requesting that I have a small case study here, just one case.
Pardon?
I have a case scenario here. Should I share it or what?
Oh, I think you can share it.
Okay, let me share it. Are you able to see it? Right?
Oh, okay.
Are you able to see it?
Yes.
Maybe we can. Okay, at 35 years old, female admitted with pain lower abdomen following abortion by village midwife 3 days back. She has been having high grade fever and bleeding from gums for 2 days. Now she has been unconscious for last 3 hours. On examination, she is moderately built and nourished and unconscious. Her blood pressure pulse are not recordable, while the respiration rate is 40 per minute. She has pallor, oral bleeding but no jaundice, cyanosis, lymphadenopathy, and then assaultation of chest, short bilateral, cramps, and wheezing. So discuss the clinical correlation with pathogenesis of the features.
Okay. Discuss the clinical correlation with pathogenesis of the features. So we'll quickly look at this. This is a patient, 35 years old female, admitted with pain in lower abdominal following abortion by village midwife. That's key. She has been having high grade fever. That's also key. She's also bleeding from the gums for 2 days. She has been unconscious for the last 3 hours. On examination, she's moderate built, unconscious. Her blood pressure and pulse are not recordable. So respiratory rate is that. She has pallor, oral bleeding, no jaundice, no cyanosis, or lymphadenopathy. Expectation of chest shows bilateral cramps and wheezing. Who is going to help us with one? Discuss the clinical correlation with the pathogenesis of the features. Why is this patient presenting like this? Anybody? So this patient underwent abortion by village midwives 3 days ago. So looking at this whole scenario, I think we can safely say this patient has got septic shock due to this abortion by midwife. So she may, this probably has sepsis. Or probably we could even say this patient has postpartum hemorrhage, septic postpartum hemorrhage. Septic postpartum hemorrhage, because she underwent abortion and she's presenting with a fever. Yeah. So in terms of shock, we can safely say she has septic shock. Yeah. And what is bringing about this bleeding in gums is most probably because she has also undergone. She's also having DIC, which is disseminated intravascular coagulopathy. Yeah. Then she has been unconscious because she's bled a lot. Perfusion to the brain is impaired. Then what other signs do you need to explain here? Blood pressures and the pulse are not recordable. Yeah, she's definitely in shock. Then respiratory rate is 40 per minute. She has pallor because she's lost blood. She has bleeding, which is attributed to DIC. There's no jaundice, of course, we don't expect jaundice. Cyanosis or lymphadenopathy. Yeah, I don't know if you have any thoughts which are different from.
Yeah, maybe I can add
Yes.
on the clinical correlation.
Mm-hmm.
Here we can say that the woman underwent an abortion under poor hygienic conditions.
Yes.
In the village, the midwife. So under poor hygienic condition, and therefore it developed serious sepsis.
Yes.
Right?
Yes.
Yeah, maybe you and then her bleeding from the gums is maybe due to reduced platelet count from the accompanying of sepsis. Now that can be the cause. And then the unrecordable blood pressure and pulse along with the rapid breathing are due to hypotension and maybe metabolic abnormalities. So that's due to hypotension.
Yes.
Yeah, I think that one.
Yeah, so what is the diagnosis?
So the probable diagnosis that is septic shock.
Secondary to what?
Yeah?
This septic shock is secondary to what? So we should note that she has been having high blood fever and now she has been. Okay, yeah. This is we can safely say it's septic shock. But
Yeah, the septic shock.
by the cause it's that abortion. Then how will you investigate and confirm the diagnosis?
The investigation and confirm for the diagnosis. Maybe
Let's not leave everything to the doctor.
Yeah, maybe someone can add with that. Diagnose the investigation.
So for the investigations, since we're suspecting DIC here, so I think we can do a prothrombin time. We can also do a PTT. Then also, just to confirm the septic shock, we can do a blood culture to just try and isolate the causative organism. Yes, I think those are the investigations that I can mention.
Okay. Anybody else? Any additions?
Yeah, exactly as you said, a full blood count or a differential count to see the white blood cell count if it has been increased to confirm that there's an infection.
Okay, thank you, Nango. I think that's good much. Anything else? I'm sure we're just trying to we do a full blood count, a differential count, we do the coagulation studies and all those things. Yeah.
Yeah, that is the case.
Maybe Jews.
So I'm sure is this different from what we discussed?
Yes.
Yeah, so I'm sure you can share this to the group and people will be able to read.
Yeah, I'll just share right away.
Okay. Yeah. So thank you so much. It's a very educative scenario. I'm sure you're going to see that one of the commonest presentation of a patient with shock is in labor ward, where you have patients presenting with postpartum hemorrhage. Yeah, common postpartum hemorrhage, which can also be secondary, which could explain even that patient. Yeah, then so it's a very relatable and important scenario you've got. Thanks so much. Okay. I don't know. Over to you, moderator.
All right. All right. Thank you so much. We're going to have, we've really gone way beyond time. We apologize for that. We're going to have closing remarks by Samichi Kinaka, our finance director.
Thank you very much. Doc, it was quite an elaborate presentation. I've quite really enjoyed the presentation and the interaction. But before we close, I was thinking maybe we give an opportunity to Dr. Ziwa. I don't know if she's around.
No, I don't think she. It's okay. She doesn't. I don't think she wants to speak, but she is here. Oh, and you want to say something?
Not much. It was an interesting presentation, and I'm glad to see that we have young minds that are so interested in medicine. Yeah, it was interesting. That's all.
All right, thank you very much. And, when you've got a senior in your presence, at least you have to give them a chance also to share your thoughts rather than them just sit and listen to you. Yeah. And then I've seen that at least I've been giving for the past few months a lot about in terms of closing remarks. So at least I will accord an opportunity to anyone, preferably someone who will be able to give the actual or the closing remarks. Thank you.
Thank you so much. I really might except thank you, Dr. Danny, everyone that was here. I came a bit late. I had a class with some of my friends. Otherwise, I personally have learned a lot. I continue to benefit from this platform, and I just pray that we continue with the same spirit. Thank you so much.
All right. Okay. Thank you so much. Considering we started with a prayer, so it is only right that we end with a prayer. I'm going to ask Inonge to close for us, even as we end the meeting.
Okay, shall we pray? Our Father in heaven, we thank you for this discussion that we've had. Thank you for everything that we've